Hi, my name is Matthew Harris, and today I will be doing a case study presentation on Steve. Steve is a 33-year-old primary school teacher who enjoys playing social tennis. However, he suffers from chronic left ankle instability, rolling his ankle at least 5 or 6 times. He recently suffered a left ankle sprain 2 weeks ago while playing tennis, leading to significant pain and swelling. He required crutches to walk for the first week. However, he is now able to walk without crutches and no pain, with just a slight limp in his left leg. He also suffers from chronic pain in his left hip and groin when sitting for long periods, as well as in deep squats and playing tennis. Steve has come to us with the goals of returning to playing tennis without rolling his ankle, squatting pain-free, as well as reducing his pain when sitting. There are several areas of concern for Steve based on the initial testing results. Firstly, he has a positive ankle anterior drawer and talar tilt test on his left side. This indicates ligament laxity in the anterior talar femur ligament as well as the calcaneal femur ligament, a strong indicator of mechanical instability of the ankle joint. Steve also sees strength limitations in both inversion during MMT and plantar flexion in a single leg calf raise test. Both of these tests are limited by pain in the ankle as opposed to muscle weakness or fatigue. Studies show that the largest risk factors for chronic ankle stability are plantar flexion and eversion weakness, and as such, our priority goal for us is to improve this. Further to this, studies conducted show a limited ankle proprioception is a key indication of chronic instability from a functional perspective. On top of this, Steve also has restricted range of motion in dorsiflexion, both loaded and unloaded. This is likely to be caused by the recent ankle sprain as opposed to the more chronic ankle instability, where the ankle often sees excessive range of motion. There is also likely to be a restricted in ankle eversion range of motion, with pain due to the compressive forces placed on the damaged and swollen ligaments. On top of these concerns around the ankle, Steve also has several areas of concern upon testing around the hip joint. He has a positive for Deere and Thomas tests, which, when combined with his subjective history of pain in the anterior hip and groin region, are a strong indication of femoral acetabular impingement, or FAI for short. This is a condition involving premature contact between the femur and acetabulum, often causing pain in the anterior hip and groin region. There are two main types of FAI: cam deformities involving excessive growth in the femur, and pincer deformities involving deformities in the acetabulum, while there often is a combination of both. Imaging is required in order to differentiate between the two, with a cam deformity often indicating early signs of osteoarthritis. This is further evidenced in Steve after testing internal hip rotation and flexion, where he is limited in range of motion in both tests. These pathologies are heavily linked, with studies suggesting hip strength and stability plays a heavy role in ankle stability, and if the hip joint is compromised and unstable, this leads to an increased risk of chronic ankle instability. This is evidenced within Steve's testing by performing a single leg squat movement. He sees significant hip internal rotation when performing this movement, forcing his ankle to pronate in order to accommodate for this shift in weight. This shows a reduction in stability in the hip, leading to an increased risk of ankle pronation. There were several important safety and monitoring considerations to take into account during exercise sessions with Steve. It is vital for us to monitor his pain levels throughout the session, with research suggesting a pain level of 3 out of 10 being a safe area to operate within during exercise, with 5 out of 10 being the maximum we should hit during a session. If we find that Steve is reaching these high levels of pain, it is important to modify or regress exercises to ensure that we are not causing further injury to Steve. It is also important to ensure that Steve understands that some pain is acceptable, and research shows that pain is beneficial when managed correctly. However, it is important for him to let us know if the pain becomes higher than a 3 out of 10 or is intolerable at any stage. During the session itself, we'll be using the Ball 1 to 10 rating of perceived exertion scale to monitor intensity. Research suggests that percentage of rep max values may be a more effective method of identifying intensity during a session. However, these data points are not available to us in this case, and it would be difficult to gain a true value with the current injuries Steve is managing. And this value would show a significant increase as pain levels reduce. It is also important to ensure that Steve is performing the exercises correctly and safely to ensure maximum benefit as well as minimizing the risk of injuries occurring during our sessions with him. The initial exercise session places focus on the treatment and rehabilitation of the recent acute lateral ankle sprain and the deficiencies in range of motion and high pain levels associated with this. The goal of this initial stage of rehabilitation is to reduce Steve's pain levels on a day-to-day basis and restore his range of motion, particularly in dorsiflexion and inversion, to allow us to progress into later stages of rehab, where we shift focus more towards the ankle instability and identify risk factors associated with it. On top of this, we begin to address his complaints in the hip region, indicative of femoral acetabular impingement. This is done within his current limits of pain, with the intention of progressing over time as he gets stronger and can tolerate more loads and deeper hip flexion. Research conducted on lateral ankle sprain injuries recommends 30-minute rehabilitation sessions 4 times per week. Therefore, on top of Steve's session with us in the clinic, there will also be a home program prescribed for him, focusing primarily on addressing deficiencies in range of motion, as well as strength and proprioception, using simple and effective exercises with the limited equipment that he may have at home. There is, however, a lack of research regarding the specific parameters of strength-based exercises, such as dosage and load, and therefore we have used best judgment methods based on research around other areas of rehabilitation and not specific to ankle sprains. On top of this, there is also a large component of the session that focuses on addressing Steve's femoral acetabular impingement. Research shows us that exercise is an effective method of reducing the need for surgery in cases with FAI, while strengthening the hip region, particularly in abduction, can also have a significant benefit in reducing the risk of lateral ankle sprains. Research suggests 3 or more sessions per week, with each exercise consisting of 2 to 4 sets of 8 to 12 reps at 60 to 80% 1RM. As we do not have 1RM data available to use, RPE can be used as a suitable alternative to measure intensity. Based off the recommendation of 3 or more sessions per week, the prescribed home program will also aim at improving hip mechanics and strengthening this region, without causing pain for Steve. This will again use simple movements that he can perform at home with minimal equipment. There are several measures being taken throughout the program to minimize Steve's pain. The box squat, for example, allows us to limit his range of motion to avoid going to deep hip flexion. A movement that we have seen from testing causes pain in the hip region. Further to this, there are both regression and progression options available for each exercise, should they be too easy or difficult or lead to pain. Going back to our example of the box squat, we have seen from our subjective history that Steve is able to weight bear without pain. However, if the additional load begins to cause him pain, we can swap this out for a horizontal leg press, ensuring we are stopping before he hits deep flexion. On top of this, if he finds that the box is too easy, we can lower the box slightly, again ensuring that we don't go too low to the point of causing pain in the hip region. Over the course of the program, the goal is to move away from the treatment of the acute ankle sprain, where the main priority is to restore range of motion and reduce levels of pain, into treatment of chronic ankle instability, where the goal is to increase strength of the ankle joint itself, particularly in plantar flexion and eversion, as well as increasing strength and stability all the way up the chain to the hip and trunk. During the program, Steve will see us in clinic once per week and have a further 3 days of home programs to complete. These home programs will progress in line with the relevant goals for each stage, using minimal equipment that he will find at home. During the first stage, the main priority around the ankle is to reduce pain levels during movement, as well as increasing balance and hip mechanics to allow us to progress into more advanced stages of rehabilitation, focusing on the more chronic conditions. During the second and third stages, during the second stage of rehabilitation, we begin to focus on more advanced exercise, strengthening the ankle and all the way up to the chain into the hip and trunk. We begin to utilize tools such as wobble boards to make balance exercise more challenging, as well as more advanced exercises such as step downs. These are great exercises for Steve as they allow us to effectively strengthen the hip region while minimizing the amount of hip flexion required. During this stage, we will also begin to introduce some low-level plyometrics to begin to reintroduce impact. The third and final stage of the program is essential for Steve to begin to reintroduce running and change of direction. By this stage, Steve should have restored range of motion and have reduced pain when sitting and squatting to 90 degrees without pain. If Steve is able to meet the progression criteria, it will be safe for him to return to playing tennis with minimal risk of re-injuring his ankle. Research shows that an effective way of easing Steve into returning to tennis is to provide an ankle brace. This will allow him to return to tennis with increased stability in his ankle as well as increased confidence. This should only be a short-term measure to get him back and should not become something that Steve relies on in the long term. After Steve has returned to playing tennis, it is essential for him to continue to strengthen the ankle and hip. It is important for Steve to retain the strength he has gained and allow him to continue playing tennis without further injury.